blunt trauma. The diaphragmatic injuries tend to miss in most of the time because they are very small in size. Sometimes there will be large diaphragmatic injuries. In that case, it will be clinically obvious and probability may be able to pick up in early stage. Straight away we will get into the case scenario. My patient is 29 years old male patient admitted to the district hospital following an elephant attack somewhere around 6:30 p.m. On admission, the patient complained abdominal pain and shortness of breath. And according to the information in the sheets and at the presentation, patient has no major injury other than the abrasion in the right side chest and the abdomen. He had no extremities injury and he had no head injury. After the initial assessment and the resuscitation, patient was transferred to us. So we received the patient somewhere around 9:15 p.m. On admission, his complaint were shortness of breath and abdominal pain, the same complaint what he had at the peripheral hospital. So once we get the patient, we assess the patient in terms of A, B, C, and D. The patient airway was patent and the cervical spine was protected with cervical collar. Patient was tachypneic with a respiratory rate 42 per minute and his trachea was central. And the percussion note was resonant, and we noted that the patients having diminished air entry on the right side, basically on clinical ground, and the patients having pneumothorax on the right side. Patient pulse rate was 104 per minute with a blood pressure of 100/60. He was quite conscious and rational, and DCS was a 15 out of 15. As patient complained abdominal pain, we went ahead with the abdominal examination. There we noted that there was an abrasion in the right upper abdomen, and on palpation, patient had diffuse tenderness with guarding. He had no major extremity injury other than the few abrasion as I mentioned earlier. For the resuscitation wise, we set up 2 IV line with a white blood cannula, and the necessary blood was taken for the investigation, including grouping and cross-match. On clinical ground, we placed the right side IC tube, and there we noted that the bubbling air bubble in the bottle, which confirmed our clinical diagnosis of pneumothorax. Patient was improved symptomatically. I mean, the shortness of breath was improved with IC tube. Thereafter, we gave oxygen through the mask and catheterized the patient, and in the meantime, we organized fast scan, which revealed little free fluid in the abdomen, but they haven't commented on the main organ, especially liver and the spleen was not commented. So with this background, I took this patient to the ward and kept the patient on strict observation. And there we noted that though the patient's shortness of breath was improved with IC tube, his respiration rate was not improved. That was fluctuated between 40 and 46. In the meantime, the patient was oxygen dependent. And very interestingly, the patient's circulatory systems deteriorated. That is, patient developed tachycardia and hypotension. Basically, patient had tachycardia and hypotension with tender, rigid abdomen. That was quite enough for us to go ahead with the laparotomy. Unfortunately, the hospital where I worked and had no CT facilities to assess before we embark on the laparotomy. We did the laparotomy roughly about 2 hours after the admission. So these are the laparotomy findings. And patient had large bowel injury, mainly transverse colon, jejunal injury, and pancreatic contusion. And excitingly, this patient had right dome of the diaphragm injured with the liver herniation into the thorax. So once I noted that, with the permission of the anesthetist, I went ahead with the thoracotomy. These are the pictures of pictures taken during the surgery. And in fact, if I have the pointer, I tried with the pointer, but unfortunately that's not working with these digital things. And you can see jolly well the diaphragmatic laceration and gallbladder through the lacerated wound. And right lobe of the liver was in the thorax and left lobe is in the abdomen. So here you can see the diaphragmatic injury very nicely. So with the permission, I went ahead with the thoracotomy. These are the pictures. This is one of the pictures I took during the thoracotomy, where you can see the lung tissue and the liver. So after dealing with each and every injury, I admit the patient to the ICU. There we gave the ICU care for 27 days, and the patient was discharged on 37 days. In conclusion, even though rupture of the diaphragms due to blunt abdominal trauma is rare, the presence of it is very significant. Unless we identify it timely, we might end up with a complication and devastating outcome. especially in this case, and what the message, take-home message is, the rare possibility of diaphragmatic rupture should be kept in mind when you place in the chest drain on a blunt abdominal trauma patient. The point I want to highlight, when you place in the chest drain, you have to take all the precautions not to damage the underlying structure. Especially in my patient, the liver was inside the thorax. Just in case, if you just put the IC tube, sometimes the tube may be inside the liver. And if that happens, patient might be to death. So that is why I said that most of the time we get the trauma patient, the trauma is there. So what we do, we handle that whatever the damage is there. But very important to see whether we are minimizing or we are preventing the secondary injury once we dealing with the trauma patient. So in this patient needed IC tube. So when you are placing the IC tube, we have two types of IC tube in the hospital setup. That IC tube with trocar and IC tube without trocar. In general, in trauma management, we advise medical officers to use the IC tube without trocar, because there's a high chance of damage with the trocar IC tube. Once we dissect the thoracic wall, we use the finger to create the or dilate the tract, so that if there's something underneath the parietal pleura, the pleural cavity, we can feel that whatever the organ. So in that case, we can take precaution, and say there we can safely introduce the IC tube. So you can see in the upper pictures, we are just using the finger to do the blood dissection. Thereafter, introduce the IC tube with the forceps and without any problem. But on the right down and the left side of the down screen, you can see the IC tube with the trocar. So these are the IC tube with the trocar. Just in case, if you're using the IC tube with the trocar, what we do, we make a small skin incision. After that, we just push the IC tube with the trocar. In that case, once the tissue is given away, so there is no resistance. So the IC tube, the trocar will go and damage whatever the underlying structure. In my case, there's a high chance of damaging the liver. So that is why one of the important things in our hospital setup is try to prevent or minimize the secondary injuries when you are dealing with the trauma patient. So always in trauma setup, we suggest when you are putting the IC tube without a trocar. But this sort of IC tube with the trocar is good for the battlefield. This is the end of my presentation. If you do have any questions, I'm quite happy to answer.
Thank you, Dr. Besinger. You finished well in time with giving us 1.5 minutes extra, in fact.
Yeah.
So any questions, please address Dr. Besinger. So judges have any questions?